Our next speaker, there was a great segue, I should say, from Mr. Fuller when he spoke about the importance of human connectivity, but he also mentioned that where technology is going, which is a great place to introduce our next guest, which is Dr. Michael Koriwchak, in case you were wondering how to pronounce it, let alone spell it, who's an ear, nose, and throat or an otolaryngologist, and he's also a health IT programmer, so he's considerably overqualified for potentially both of those positions. He received his medical degree at Duke University School of Medicine in 1988, completed both internship in general surgery and residency in otolaryngology, head and neck surgery at Vanderbilt University Medical Center. He continued at Vanderbilt for a fellowship in laryngology care, try and say that 3 times fast, and of the professional voice. So that would be singers and professionals. So you have to take extra care in those that use their voice for their profession and their income and their livelihood, if you will. He's board certified by the American Board of Otolaryngology Head and Neck Surgery. He's been working as an information technology person since 1977. I guess you had one of the original Trash 80 computers from Radio Shack that was black and white with discs as big as your...
Oh, what, the old TRS-80? Yeah.
Yes, exactly.
Yeah, we did.
So it's good to know that you've been in it for that long. You've been 18 years in private medical practice and 30 years of IT experience and built your own EMR system many years ago. And you're going to discuss EHRs and their future potential.
Thank you. Much. Let me add my name to the chorus of thank yous and gratitude to Dan and Mike and Judy and Gina for putting this together, and to thank you for the privilege of presenting to you not once but twice, because we started this with a webcast on Monday and sort of talked about what has been talked about all week, which is, what a disaster the Meaningful Use initiative has been, and how that's forced electronic medical records to be what could be a good thing to, at least for the moment, be a rather bad thing. The downside of having two opportunities to speak is that you can't really give the same talk twice. And so I realized yesterday I had to kind of put something together sort of in a hurry, and with all of the talk that's been going on and all the emotion about electronic medical records, I felt the need to sort of respond to that and kind of crystallize all that into something that we can take forward and actually make good use of. Let's see, how are we doing slides here? Can we go next slide? Is this it? Okay. You got it. I'm pushing every button on the top. Oh, there we go. It's the big button. There we go. Okay. So again, few issues have raised emotions like this whole electronic medical records thing have, and I think we all agree that the EMRs that we're forced to deal with currently aren't that different from the old Edsel. For those of you who are youngsters in the audience, that's a car. And it's a rather famous car that if you're around the age of 50, you remember this. The Edsel was regarded as such a bad car that it became the cliche for anything that was a failure or anything that was badly designed or poorly executed. The irony here is that the Edsel actually had a lot of neat technological advancements in it for a car of the time. It had buttons on the steering wheel, right? And all our cars have buttons on the steering wheel now. It had self-adjusting brakes, which was a big deal at the time. Well, every car has self-adjusting brakes now. And so I bring this up today to suggest to you that sometimes there might not be that much difference between a good idea that's badly executed and fails and a good idea that's executed well and succeeds. So very briefly about my background. I've been at this for quite a while. And the end point of that is that our practice is kind of like a learning lab for EMR. I'll go home at 9, 10 o'clock at night, write some new code for our EMR to modify a template or something, and try it within hours the next morning and see if it works. And sometimes it works, and sometimes it's really awful. And so, the difference between me and the EMR vendors is I'll embrace that very quickly and fix it, as opposed to saying, no, sorry, you just need to use it the way it is because I can write code and you can't. So anyhow, we all agree. A brief review from last time. Meaningful use was a mistake. We all know this was ridiculous. It's harmful. It's reckless. It's crazy. It was stupid. It was done because 100 doctors in one lousy interview said that they liked their EMRs. There was no objective data. But there is one little extra piece of this that I would like to suggest to you, and maybe you don't want to hear it, but I think we physicians do share a little piece of the blame here, because in the years leading up to 2008, when I was trying to convince people this was a good idea, this is what I heard. So be careful what you wish for, and how's that working out for us? I think we all agree not very well. So we're going to replace the negativity with a positive approach and an alternative vision. I'm going to show you how to take the EMR that you've got and that you were forced to buy and do something with it that actually contributes to the value of your practice and makes the product work for you. We're going to replace discontent with an alternative vision. The promise of health information technology is real. These are real numbers from our practice. Our EMR saves us almost $25,000 per doctor per year. Those are not ethereal numbers. Those are not estimates. That's real. And, we're going to go over how we did that, of course. And again, to emphasize, it doesn't have to be this way. EMRs don't have to suck. Right? And a return on investment is absolutely possible, but you got to have some guts. You've got to have a leap of faith to don't just drive the car, but get under the hood and fix things and build this into your practice in a way that it actually adds value. We talked about the Ebola thing. Yes, EMRs can do harm. I'm going to skip over that and move on with limited time. Again, the message is we need to control the dialogue. We enter this discussion at a disadvantage because it is intuitive to the public that the computers are good, and that and we need to emphasize that yes, computers are good, but they can harm. Right? They can kill, as we know from the America's first Ebola patient. We have not adequately developed the basic and clinical science like we have with all other medical specialties, such as thoracic surgery and gastroenterology, what have you. And I would submit to you that health information technology is another branch of medicine that needs the basic and clinical science, just like other branches do. And right now, EMRs do harm because we don't have that basic science, and yet we're forced to practice anyway. So, let's get into the meat of this. You were forced to buy an electronic medical record. What the heck are you going to do with it now? You bought it, you got your meaningful use money, but you're still paying annual license fees. The thing is still costing you a couple of extra hours every night. What the hell do we do now? So the first thing we're going to do is I'm going to try to apply some of the things that I learned from Lisa Chu over here. And we had long talks last night and the night before, so I'm going to try to apply some of what you taught me here. So what I would like you to do is kind of take a deep breath, and close your eyes and forget about meaningful use and visualize your world with an EMR that works, with an EMR that adds value, an EMR that you like using, an EMR that makes your life easier, not harder. And then ask yourself, what does that world look like? And I'm going to give you my best answer to that question of what that should look like, and give you sort of some guidance as to how to get from where you are to where you can be to make your EMR actually do something useful. Physicians know more than anyone else. You know more than you think you do. Again, it's this leap of faith that you don't have to just give this up to the vendor and say, fix this, I'm going to go see patients. You've got to work with your vendor and get this stuff to work the way you want it to work. So what is practice made of, right? We have the important stuff. We have the doctor-patient contact, the doctor-patient relationship we've been talking about all week, and we have everything else. And the key is, I think we would all agree, we don't need a damn computer for this part, right? We do this well just fine, thank you, and I don't need a computer as much as I'm a techno geek and like all this stuff. I don't want a computer telling me what to do. I don't want a computer pushing options to me in an exam room because I don't need that. That's not what EMRs can be most useful for. It's everything else. It's all these business processes that have to exist in order to support this. So what are the four functions of an EMR that can support your practice? Remote access, communication between people, data capture, and workflow. And we're going to spend most of the rest of our time talking about this workflow piece. So what do you got to do? Again, keep your eye on the ball. This is about reducing overhead and not much else, right? What's the low-hanging fruit here? Transcription costs, right? It's not unusual for a large practice to spend $140,000, $150,000 per year on transcription. If you get your EMR up and running well, those costs disappear. They disappeared in our practice, and we watched it happen over about 12 to 18 months, going from $150,000 a year down to zero, period. You can get more efficient use of space. We convert non-revenue generating space to revenue generating space by having our surgery schedulers, our billers telework. We got rid of our file room, of course, because we didn't have more paper charts. But this doesn't happen by magic, folks. You don't just plug the darn thing in, turn it on, and have the good stuff just happen. You've got to have those goals in mind. You have to have those landmarks on your horizon and always be pushing towards those, because if you don't, you get the situation that Dan talked about this morning, which is you buy the EMR and then you hire the scribe, and wait a minute, I'm spending more money, a lot less money. You've got to think through that, and if you can, you'll get to a point where you're using less on payroll, less on rent, and more on the stuff that you want to really care for patients with. Again, the workflow function is the most important function. We're going to talk about this a lot. Other parts of the economy have got this figured out, right? We know we all flew here and we got our airline ticket online, and that all works well. They got that workflow figured out down to a science. Other parts of the economy, same way, except for us. We don't have workflow well developed in the practice setting. So what is it? What the heck is workflow? It's a new term and something that you're going to need to get familiar with if you want to take this thing that you spent hundreds of thousands of dollars on and really start getting your money back out of it. All right, it's the steps to get something done, right? You decide you're seeing a patient, you're in there talking to him, you decide you want a chest x-ray. From the minute that synapse fires up here that you want the chest x-ray to the moment you're holding a result and a report in your hand, there's things that have to happen which aren't that much different than what happens when you book your airline ticket or FedEx ships your package. It's all about the same. So here's an example from our office. This was something that before EMR we had a problem with. We were not doing well with patient phone calls. A lot of complaints. I called, nobody called me back, et cetera, et cetera. And it was because it was all at random, right? There's lots of different ways that when the phone rings in your office, somebody can transmit that message to you, but there was no standardization. And when we would try to standardize it after some kind of near disaster, entropy would gradually creep back in, and the people who were trained would turn over, they'd go to another office, and pretty soon it all fell apart. So what happens when you use an EMR for something like that is you can standardize the workflow and you can design it. So now we take our phone system, we route all the phone calls to one person. And that one person can be anywhere. They could be here, logged into the EMR, picking it up from the phone system, forwarding it to their cell phone, and then they can triage those calls, right? If it's something easy like a prescription refill and they've been in recently, they handle it themselves, up to, urgent stuff, post-op bleeding, something like that. And obviously the way you handle that depends on the severity of the problem, but it's standardized and it's encoded into the system. Somebody took my water. Can I get some water up here? So all our complaints went away because this became standardized, and key to that standardization was the remote access that you get from an electronic medical record system. It gives you the freedom to centralize a workflow, decentralize a workflow, design things so that they work well and they continue to work well. So again, we're going to talk a little bit about basic science now, a little bit of basic science of workflow. That stuff that's missing, that does not allow us to practice well with an EMR. We've scratched the surface. We certainly don't know all the answers in our practice, but we've scratched the surface a little bit. And so here's a little bit of what we've learned, is that when you're doing these steps to get things done, there's two ways to do it. There's sequential processing and parallel processing. So let's talk about those for a minute. I'm a car guy, right? You saw the Edsel. So we're going to do another car example. Let's say you need new tires and you live in a small town. Maybe Dr. Armstrong's got just one mechanic up in the Upper Peninsula of Michigan that he can go to for new tires, right? So he goes to that mechanic. It's a one-man shop, and he says, look, it's going to take me a few days to get your tires changed. I got to order them. I got to wait for them to come in, and then I can only do one tire at a time. So that's going to take a long time. The phone's going to ring. They have to answer it. Everything's interrupted. Everything's disrupted. So it's not going to do well. Contrast that. Oh, here's the steps. Again, we just revised this talk another 20 minutes ago. Everything's in crazy order. So what happens, right? You got to do all of these steps, but you only do them one at a time, and you can only do one wheel at a time because you only got one guy, right? What happens at the Indy 500? Things are a little different, right? What takes the solo mechanic 6 days gets done in 6 seconds, and if it takes more than 8 seconds, it's a failure. And by the way, they also got a full tank of gas, a drink for the driver, cleaning the windshield. This is parallel processing. Multiple workflows going on at once. All 4 tires get serviced all at once, not one at a time. This is what an EMR lets you do. Let's see how that works. Let's talk about what happens in the doctor's office, which is one of our most common workflows, of course. is preparing patients for surgery. Well, what do, right? Well, you're familiar with this. All sorts of things happen. One is, obviously, you have to document why it's indicated, communicate with the referring physician. Then you've got a scheduler who's getting all this stuff done, scheduling pre-cert, pre-op workup if you need it, specialist clearance, what patients calls with a question. You got all this stuff going on between the time you say, yep, they need their tonsils out, and the time it actually gets done. What happens with paper charts and sequential processing is you got these stacks of charts everywhere, right? Surgery schedulers got a stack of charts. My medical assistants got a stack of charts. Whose stack does it go on? Say they need surgery, they need the thyroid out. Do I give it to my surgery scheduler to start that process? Do I give it to my MA to get my clinic note, my paper note? Where's that chart go? The problem is job 2 can't get done till job 1 gets done. And this is incredibly inefficient. And what happens while you're getting all that surgery scheduled, if the patient calls with a question, then they come and, the person answering the phone pulls it off the surgery scheduler stack, answers the question, gets it handled, and oops, forgets to put it back on that stack, files a chart in the file room, right? But this was the only documentation of the work that needed done. And so what happens? Patient calls a week later and says, where's my tonsillectomy? Nobody called me. So that's the kind of stuff that happens in a paper chart world where your only option is sequential processing. What happens with an EMR? You get the parallel processing, right? Now I go in there, I sign the note right away, so documentation workflow goes away. But now I send a flag to my surgery scheduler, I send a flag to my MA, I print all the forms. It all happens all at once. And multiple people can attack that chart all at once. And oh, by the way, if the patient calls with a phone call, no problem. My phone call person in the phone call workflow in a different office has access to the chart, can answer the question, send a flag wherever they need to if indicated from the phone call. And so all this stuff runs, and it runs tight, and it runs well, and there's not the level of workflow failure. In fact, almost no workflow failure. And you don't have people losing the chart, looking for the chart. That's where the power of this stuff comes from. It doesn't have a damn thing to do with meaningful use, quality reporting, blood pressure checks, and all that kind of crap. It's in a completely different world that you're not going to discover unless you can get your mind away from this meaningful use stuff, right? Close your eyes and visualize where you need to be. So here's what we've got in our EMR. I call it the workflow engine. Okay, again, I've got one button that I can click for any of these operations, right? We've got dozens of these in the workflow engine, depending on what you're doing, but if they need a total thyroidectomy, I hit one button, and all those workflows start. Flag to my surgery scheduler, flag to my MA. All the consents print, the pre-op orders print, the post-op order prints, prepares for the H&P, although that's one more step, and all this stuff gets done, and we did sort of the motion studies on this, to try to figure out how long it takes human hands to do all this. We probably save between $4 and $6 every time you click one of those buttons, because the computer is doing the scut work. That's what it's supposed to be doing. I don't need it to tell me how to be a doctor. I don't need it to remind me of stuff. I need it to do the scut work, and that's exactly how this workflow engine is set up. So that's where the return on investment comes from. It comes from parallel processing, remote access, and the ability to get in under the hood, change how all of these business operations occur in the practice so that they become very neat and very tight and far more reliable. And the result of that, believe it or not, is more time with the patient, not less, more efficiency, some cost reduction, right? We told you 25 grand per patient per year. And the ability to maintain these workflows through time, change them as you need to. When you acquire a doc or a doc leaves or things change, you can change all that stuff in the system to keep things running tight. And then you've got to circle back around. Keep your eye on the ball. What am I doing here? I want to do my job with less space, less payroll, less transcription. But if you don't keep your eye on the horizon and keep up with those goals, you're not going to get there naturally. It's got to happen with a lot of planning and a lot of thought and a lot of education as to how workflow operates, so you can take these things to your own practice and actually take this piece of garbage that you were forced to buy and actually have it do something useful. And oh, by the way, the meaningful use money, if you look at the numbers, I think that's the next slide. Okay, here's the breakdown of the how it goes. Again, direct savings, most of this is transcription. That's about 12,000 of it. You're not spending money on paper materials to make charts anymore, which is far more expensive than you might guess. So 14,000 a year comes here. Again, space savings, either less space or conversion of non-revenue generating space to revenue generating space, right? Add more exam rooms without paying more rent. Add a procedure room. We added hearing aid consultation rooms. That's how we're making more money. And the FTE savings, which is a little more difficult to measure, but again, it goes to workflow automation, right? We got lots of staff that works from home. They love it. We haven't given them a raise in 4 or 5 years because they got so much money not having to drive in Atlanta back and forth to work, they didn't need a raise. They got after-tax savings by not having to drive. So again, let's compare. Meaningful use, $44,000 over 5 years. ENT of Atlanta, $122,500 per physician over 5 years. And guess what? This goes away. This does not. So a couple of other things, and this is kind of response to some of the earlier talks here. This is, again, another piece of the basic fund of knowledge we don't have, this bedside manner in the information age, right? Everyone says, I hate this thing. I'm over here on the computer, and I've got my back to the patient. Absolutely legit. But there's a whole science to modifying your bedside manner when there's a computer involved. Again, it doesn't have to be bad. People said that about the stethoscope 300 years ago, I think, that the stethoscope was an intrusion on the doctor-patient relationship, but that's become a staple of what we use. There's no reason that technology at some level can't be the same. Right? Think about what happened with thyroidectomy, right? I do a lot of these. Bill Roth actually blew off thyroidectomy after doing them for 10 years because the mortality rate was 41%, right? Back in the late 19th century, people died from what? Blood loss, cord paralysis, hypocalcemic tetany, all that stuff. Thyroidectomy was unworkable then, right? But when you figure out the details and manage those problems, now thyroidectomy is an hour and 45-minute procedure that's an outpatient procedure with no drain, Dermabond dressing, go home. It's a completely different world. Thanks. You do questions, I guess.
Thank you very much, Dr. Koriwchak. I think we have 5 minutes for questions. If anybody here in our studio audience, if you will, has any questions about EHR and their application. Dr. Arvind Cavalli.
Mike.
Hey.
Hey, from one IT lover to another one. Question, actually a caution. You did mention about the allowing the EMR to do your scut work.
Correct.
A real life example where the pitfalls of that could be a little difficult to handle. My wife had surgery last year, and when she looked at her notes online, the consent for surgery was nothing what she had signed to, because the surgeon didn't really go through all the pieces that were mentioned in the pre-formatted consent document.
Oh, absolutely.
So one of the cautions, as I would say, is please make sure you do what you actually say you did on the EMR. Otherwise, you'll have a lot of things to answer to.
Oh, absolutely. I mean, that's just one of the pitfalls from us being forced to do this without having all those, potential mistakes worked out, right? I mean, this drives me crazy, right? I mean, what's the propaganda that comes out of Washington? Oh, EMR eliminates errors, right? Makes things more. Well, it doesn't eliminate errors. It replaces the errors that we're familiar with errors that we're not familiar with, right? If a doc writes a sloppy prescription, okay, we get that. Pharmacist knows how to handle that. You pick up the phone, you fix the problem. If the electronic script comes in e-scribed and you hit the wrong button, right? If you hit amiodarone instead of amoxicillin, right, which are close together in the alphabet, right? It comes in nice, neat prescription, says amiodarone. How you gonna figure that out? So the errors that electronic systems cause are far scarier. And again, this needed to be done slowly, but we're through that door and there's no going back, sadly.
Another question. Can you identify yourself and then ask your question?
I'm Claire Coco. I'm here from New Braunfels, Texas. The question I have is your specific recommendation to modify your exam room regarding the workflow. I have 2 exam rooms that I basically are kind of right and left mirror images of each other.
Okay,
And I
yeah.
have trouble in one of them because I'm right-handed. And
Yep.
so what is your suggestion on that?
You'd almost have to get in there and walk around and figure it out. It's rare that I touch the EMR in the exam room. My answer to the whole scribe problem is that the person who's in the exam room with me is a combination scribe assistant. So part of what they're doing is capturing data as I'm talking and examining. But the other part is because we've got this workflow engine in place, they're doing more than scribing, right? They are initiating workflows. I'm telling them to click the button for the thyroid. And so I'm getting more out of that FTE, but they're the ones touching it. So the whole mirror image thing doesn't hit me as hard as the doc. And I kind of let the staff, they're, depending on personality and whatever, I let them solve those problems on their own, or if they need, we work through it. But you're right, those are legitimate issues that need to be looked at. But it's different for every doc in every room.
So question, you don't want to use a scribe because you don't want to have someone else privy to someone else's information, because that's potentially a privacy issue, and you can't afford a scribe. How does a physician in, say, solo practice or small practice, some type during the exam, and some patients find that depersonalizing. Other times you do a quick exam and then you run out and spend 15 minutes typing in the hallway.
Right.
What kind of workarounds, or how can you make that productive?
Sure. Glad you asked. That's a workflow question. When we do our documentation, and I have to say this carefully, the documentation is assembly line, so the care isn't. So by the time I see a patient, 90% of the note is done, right? The HPI is done, except for when I interview the patient and add another sentence or two. All the other stuff, review of systems, meds, allergies, family, social, all that stuff is done. All I have to do is read it. And the only data entry that I do is like a good old-fashioned country doctor note. It's a 3 or 4 sentence assessment. And anything that is pertinent to that patient's case goes in there, right? I might say, 46-year-old female with a 3-month history of an enlarging thyroid nodule. Ultrasound shows a solitary 2.3 centimeter nodule. FNA is highly suspicious for papillary carcinoma. Schedule thyroidectomy. That's it. That's all I do. I do it by dragon, and it's done. And so I don't have to touch any of that other stuff. And I don't even have to put anything in the plan, because when my assistant clicked the total thyroidectomy button, it inserted the plan. It said schedule total thyroidectomy, risk of vocal cord paralysis.
Just don't press the thyroidectomy button when you're talking tonsillectomy by accident, because then, and I've seen that kind of thing happen.
That's right.
And unfortunately, it can go from malpractice to fraud if your system actually bills for a procedure that you didn't do. So
Correct.
That's a huge
and that's,
caution.
Again, the missing fund of knowledge is revealed in those situations. And the thyroidectomy tab and the button and the tonsillectomy button are on different tabs, right? You couldn't confuse those, but you could confuse the lobectomy that's right below it. And again, you don't trust the machines blindly, right? When this thing spits out paperwork, I read it. I look and say, yep, this is a thyroidectomy. Yes, it's got all the right stuff. It's got the right doctor's name on it, et cetera, et cetera. But yeah, garbage in, garbage out. That's still accurate.
Right, okay. Was there one more quick question? Because we only have another minute.
Sherry Laubach, family practice in Denver. It's probably easier for you to document than it is for those of us in family practice who have to deal with the hypertension and the diabetes and the high cholesterol and the obesity. Do you have any suggestions for that?
If you're implementing, I would start with your most common stuff and build templates that work for that, and then kind of expand from there. But yes, and again, as a specialist, I can't say I have any direct experience with that. But I would probably start with what you see the most of and work that out, and then expand from there. My guess, my poorly educated guess, is it's not as different as it may seem. But that's a highly speculative guess.
Thank you, Dr. Koriwchak. Appreciate you being with us today.